So if you will notice, most of us who are radiologists will know a comminuted fracture of the humeral head, which is actually being read right now in our institution. AI, pops up and says, yes, you've got a fracture there. And I think this comminuted fracture right now is somewhat emblematic of the state of radiology workforce. So in the next 45 minutes, I need to think of Olga and her time here, right? I'm going to quickly summarize for you the history of radiology workforce in the last 30 years, the impacts of accumulating policy and demographic changes. By God, there are quite a few. The current challenges to radiology education, and really quickly, promise of technology, because Olga will be expanding on it significantly more than I will. All right. If an impression to this long report would be this: we are faced with massive mismatch between the demand for our services and the size of our workforce. This is leading to, led, is leading, will lead, whatever, put the tense there, all three of them, to dissatisfaction, turnover, burnout amongst us, the radiologists. Our education is under pressure because it's going remote. And, there are promises and there are threats of artificial intelligence. All right. Those of us who lived through this period in the last 30 years. By the way, Liz Wave and I graduated in, I'm telling all, okay, finished our residency in 1995. We remember the acute peaks and troughs in the job market, yes? Right? Okay, so 1 year we have no jobs, 5 years down the road, we have 1 million jobs and no radiologists. How did we get here? And if you have peaks and troughs like that, you cannot plan. Basically, I cannot argue to the Association of Program Directors in Radiology that we need to expand our residency programs, because I know that 5 years down the road, Rubaya might not have a job of her choice. All right. So how did we get there? In 1990s, remember those? Healthcare is too expensive, right? We have the attempted Clinton healthcare reform with managed competition, global budgets, increased utilization of primary care, and this restricts access to imaging. The thought is that there are too many of us specialists, including radiologists, and that we are really not essential. We should not, quite so many of us should not be here. Right, and there's considerable accord. That means everybody says, everybody, right, that reducing the supply of specialists is the way to go. I have an MPH, and I actually studied with Sherry Gleed, who then became the Undersecretary of Health and Human Services for Obama, and she was the one who actually put together the website, the insurance website. And she published later on in Health Affairs the explanation why was that expensive. And in fact, the cost of us specialists has a lot to do with it, right? So in some respect, the costs were, attributed correctly, but the conclusions were, well, questionable. Anyway, in 1994, radiology practices stopped hiring, right? Because there's pressure on utilization. Jobs disappear, and medical students stop applying to radiology. Let's keep that in the parking lot, because the medical students and their application, the behavior is a perfect proxy for our job market. A little more on that in a second. All right, so there's planned reduction in radiology workforce, and look at this. That's our future. In 1996, we have 1,154 radiology positions. I am a data junkie. I remember these things, right? Okay. Now, that year, and if those of us who are old enough remember the Black Tuesday of the match, we filled, 451 positions went unfilled. I remember that day. Okay. We spoke of nothing else. By 1997, we reduced the number of positions in radiology, encouraged by the federal and local governments. And by the way, the pilot was here in New York. And there's a 23% reduction. And frankly, this is a major factor what ended up in this situation. There are calls to increase subspecialization to add value in the face of competition for other specialists. We were concerned that neuroradiology will be taken away from us by neurologists and neurosurgeons and so on and so forth, right? Because we had experience, OB, ultrasound migrating to OB and so on and so forth. There were prescient dissenters who said that the shift from specialists to generalists will make radiologists the first line in diagnosis. Okay, just remember our PAs and NPs in the emergency rooms. And the ever increasing workloads, burnout, and premature retirements due to insufficient number of trainees, all right, in the, needs of aging population will be a fact. And they were right. In retrospect, we know that. This is, when I was trying to, explain the, peaks and troughs, I was looking for a graph, something quotable. I love references. The AGR made me reduce the number of references from 150 to exactly 99. It was a feat, all right? But so I stopped a lot of references here for your viewing pleasure. So I needed a graph, and I didn't have a graph of our position, just because, it's really, they're hard to come by. So I resorted to a proxy, to medical students applying to radiology. And, ooh, I've got my finger here on an arrow. So if you notice, there's a spike of positions. There's a drop in positions. That's the described 1995. Then the positions grow very slowly up to this day. Okay, well, we'll talk about that in a moment. But the medical students, the applications, they drop and they come up, and they drop and they come up. And this is basically what happens in the job market. This is the curve of our job market, a serious trough in lower 90s. And then over the course of 4 years, things pick up. All right, why can we use this as a proxy? That's a little bit of an aside, is because we think that our trainees choose us because of their personal inclinations, they whatever, right? Okay, however, right, objective data show that medical students choose specialty based on economic health of the said specialty. And 54% cite income expectations as a strong influence. Selection of radiology is amongst the most elastic to expected earnings, to the extent that increase in earnings by 6% is predicted to increase the share of graduate from medical school choosing radiology by 17%. Okay? Okay. Anyhow, just put this in the parking lot, talking about remote work later on. The new generation puts a lot more emphasis on flexible and predictable work hours and better balance between personal and professional life, right? And so as we are, advancing in this timeline, more and more US medical students are entering specialties with controllable lifestyles. In fact, the consideration of work-life balance was cited by 40% of medical students in 2009 and by 38%, 38, and by 48% now. So it's getting, more, the emphasis is growing. But let's go back to the centers who were proven right. Okay, the utilization per Medicare recipient, no matter how they tried, grew in 3 years. MR imaging grew by 16% per year. And by mid 90s, we had 5 people looking for a job. And by 2000, we had 4 jobs per radiologist, right? Something doesn't add up. And we're going to talk about it in a moment, all right? And the workloads, because of increasing utilization, were growing. By 2007, radiologists worked 5 hours or 10% more on average than in 1995. Academic radiologists worked 7 hours more, all right? Okay. And on top of all that, the cost containment, measures which continued put pressure on imaging. We had prior authorization, increased cost sharing, reduction of imaging of unproven medical value, and then on top of that, the financial crisis of 2008. And all that slowed the growth. It didn't decrease utilization. Oh, no, no, no. It just slowed the growth of utilization and caused weaker markets for radiologists who until recently could demand top salaries. Please note peaks, troughs, peaks, troughs, peaks, and troughs in this graph. Sunshine could not explain them. And he was saying in 2007 that something doesn't add up. If utilization of imaging is still growing and the radiology workforce is working harder and harder and isn't growing to compensate, how is it possible that we have such deep hiring freezes? And so at the time when we were writing that article, we sort of put all our heads together and polled a lot of very intelligent people, and there were two explanations, just two possible explanations. Number one, radiology job market is very unusual in that it can be uncoupled from provision of services. I'll show you in a moment. And number two, we do have a large hidden workforce reserve. Uncoupling, right? This is just I took a Google image of dermatologists. Let's talk about dermatologists for a moment. You need a dermatologist to provide a service, okay? Patient, physician, right? And stagnation in training positions in dermatology in the same time, 1999 to 2005, kept patients waiting for 5 weeks on average, all right? But in radiology, as long as equipment is available, imaging studies can just pile up, right? Those of you who were ever, as the young, moonlighted in the VA can remember how much they piled up, right? And by the way, the situation is global. This is a pilot. It's a pilot, right? Which I think it's 2023, no, 2024, I'm sorry. All right. And so this is a pilot of global backlog. So you can see head CTs, all right, 7-day backlog. And so basically the authors polled multiple institutions across the globe. Notice Poland all over the map. USA is doing really well. Israel here is, setting some records here, and so on and so forth. No, there are multiple institutions, some of them really doing good and some of them not so good. Okay, and so this is the same map for chest CT backlogs. This is chest radiograph backlogs. I am not going to point to my prior institutions, but yeah, I handle those backlogs. Okay, so, and this is number one, they can't pile up. Number two, we have a workforce reserve. Let's talk about compensation. Those of us who've ever been trained in HR, and I was, right, know that compensation comes is time and money. Okay? So take a look at the average annual vacations in radiology. In 1995, an average non-existent radiologist gets 27 days vacation. By 2007, we are in 39 days. Sunshine and colleagues have this graph, right? This is the average. See that, the round? Okay, that's the average, okay? This is us, the academics. Our vacations are not growing. By 2007, we are approximately 5 days more, but close to 25 days. Private practice always had a little more vacation and went up to 45 days on average in 2007. I don't have data. Nobody has published data on vacations in private practice right now. But yesterday, last night, as I was preparing for this lecture, I did extensive search of all sorts of forums. All right. And they're quoting 12 to 13 weeks annually. I rest my case. Okay. So academic faculty still, get approximately 25 days vacation. But let's take 9 weeks. We have data from 2007, 9 weeks. Now, radiology workforce, to this day, almost half are in private practice, although the numbers are shrinking. Okay. So if you think about it, right? If you are into income preservation, like all humans, and your practice income is dropping, you simply won't hire. You're going to come out of vacation. And now we have very large practices, a little more on that in a second. And so, you give up a couple of weeks vacation, you don't have to hire anybody. And that gives us job prospects, for our graduating residents. Anyway, let's talk about policy. By 2013, we have Patient Protection and Accountable Care Act, otherwise known as Obamacare, right? Which reduces practice expenses. All of us know what happened to technical payments for concurrent procedures. There is further growth in pre-authorization. Clinical decision support is de rigueur. We now have choosing wisely guidelines, increased penetration of high deductible health plans, and downward pressure on imaging volumes. By 2015, we have Medicare Access and CHIP Reauthorization Act. Please say that 10 times rapidly, okay? Which changes physicians' payments and incentivizing participation in accountable care organizations, which have something called quality reporting through merit-based incentive payment, which is MIPS. Not the same MIPS that I do every day as a cardiothoracic radiologist, but important MIPS nonetheless, right? Now, the radiologist's performance on available metrics is uniformly high. There's really, they're paying us to get better. We are, according to MIPS, are already pretty good. So majority of us do not report on MIPS measures. There is, larger multidisciplinary practices, therefore show better financial performance. So large consolidated systems have an advantage. This reduces incentives to improve quality in radiology and incentivizes consolidation. Okay, the total number of radiology practices from 14 to 23 decreased by 17%, while practices, large practices, 25 to 49 radiologists, are up by 33%. Really large practices, up to 99 radiologists, are up by whopping 126%. And the behemoths, okay, with over 100 radiologists, have increased by 349%. All right? More on that and the impact of this process on private practice in a second. By 2020, we all remember, we have COVID, which overwhelms the radiologist capacity. Pandemic was not kind to us or any other physicians. There's transient decrease in imaging volume, compressed demand, and then enormous rebound. There's also unexpected retirement and attrition. I'm very proud of my daughter-in-law, who's a health economist, who reported in New England Journal of Medicine in 2022 that in April of 2020, 1% of all physicians quit. Fortunately, this process did not continue, but we had, and radiologists were among them. All this leads to worsening mismatch between staffing and volumes, and calls on hospitals to adopt, embrace AI. Just put it out there. It is better than nothing. Seriously, I mean, that's a paper. It's up there. It's a reference. I have it. Yeah. Okay. So we're looking at, in addition, looking at divergence between reimbursements and utilization. Reimbursements are down in the last, 16 years by about a quarter. And the RVUs that we're producing as radiologists are up by 13%, and we're feeling it. Okay. Additional item is advanced practice practitioners. These are very respectable people, in spite the tautology in this title, all right? And the reason we're using more and more of them is because we have now a record by 2022, 92% of US population has insurance coverage. They're going to see doctors, right? Healthcare providers. They don't have access. To improve access, we put out, we engage more providers. All right. And this reliance on these practitioners, particularly in the emergency room, okay, is creating demand for radiology services. You use more imaging, and Do you remember the contrast shortages, everybody? They use significantly more contrast when they order CTs, right? And honestly, I don't have time to argue. I honestly, right? I have 300 protocols per day. So, anyway, so as the emergency room is relying more and more on APPs, right? So is the greater need for the final radiology report by the attending radiologist. But we all of us in our institutions have overnight coverage. People who work these bad diurnal shifts need significantly more compensatory time off. Usual practices, one on, two off, right? Okay, so I work 50 hours a week. I produce 150 work hours per 3 weeks, okay? And my colleagues who are covering nights work 7 days in the period, 10-hour shifts. They produce 70 hours, slightly less than half of my time working, okay? Which means that, oh, by the way, and I'm hearing through the grapevine that several institutions in the South are now going to 1 in 4, right? Okay, so that really decreases our workforce efficiency, lowers capacity, and causes what? Mismatch between volumes and staffing. Okay, now you just you just quoted how many jobs available on the website. Oh, 2000. Okay, so mine is stale mutton. All right. So we are in August 2024 when I was, looking up that last, you put the reference in and you say last accessed, right? So right before we submitted the manuscript, I did last access that day, and it was 1,400 jobs in August 2024. It's increased ever since. Okay, so in 2010, for the entire year, ACR had 611 positions. Okay, for the year 2022, we had 14,000. Right, at the same time, CT, MR, and ultrasound projections for utilizations are 4% per year due to increases in cancer and heart disease in the aging population. And our radiology residency positions are increasing by 16% per year. Okay, spoiler, in the last match, we had 50 additional positions. I just looked it up. Okay, so things are speeding up a little bit. All right, burnout among us is real. Okay, World Health Organization, occupational syndrome resulting from chronic workplace stress, unsuccessfully managed, right? Leading to emotional exhaustion, depersonalization, sense of reduced personal accomplishment. And emotional exhaustion and depersonalization, by the way, both terrible symptoms, are detectable at functional MRI, a little more than that. All right. Burnout in academic radiologists, 37% of us report burnout. Our professional fulfillment is 36%. But if you think this is bad, this is private practice. Burnout of 45% and professional fulfillment is 27%. And something doesn't add up. If remote work penetration is greater in private practice, and if it leads to better work-life balance without affecting earnings, why are they more burned out? All right. And, one of the explanations in changing nature of private practice, consolidations, less autonomy, fewer opportunities to influence decisions. And then there's private equity, constraints on clinical decisions, emphasis on profits, more conflicts of interest. All right. I'll give you the slides if you like. You can have them, right? Give me your email, I'll mail them, right? All right. Turnover in private practice is the thing. And take a look, please. Take a look at this yellow, right? Things in yellow. So lack of work-life balance is one reason. Two others are highest, lower salaries and seeking growth opportunities. You notice that work-life balance is actually in direct opposition to greater salaries, right? Because they presuppose in private practice you're going to work more, right? So we have issues there, right? What do we want, and how to get there really does not align. In academic radiology, turnover is even greater. while the ACR workforce survey says that overall 16% of all radiologists planned to seek new employment. In academic medicine, it's actually 34%. Okay, and Society of Breast Imaging members survey shows that 45% of breast imagers left or thought of leaving their practice in the past 2 years, right? So it's quite bad. By the way, just to point out to those of you who are educators, that burnout affects your trainees significantly more than it affects you, right? This recent study, was, in actually wasn't recent, in 2013, internal medicine looked at the cohort of residents versus attendings and what happens in burnout. They actually tested people and found abnormalities in functional MRI in both attendings and residents who reported depersonalization, emotional exhaustion. But when they tested them, cognitive performance was not affected in the faculty, but it was seriously affected in trainees. So watch out, our trainees are less resilient than attending physicians, and this needs to be carefully monitored and recognized. Uh, it seems that remote work is a serious palliator, right? Greater work-life balance, reduced turnaround time, better geographic and after-hours coverage, right? But the $64,000 question is, what's it going to do to consultation, scientific collaboration, and most importantly, teaching? And challenges, oops, my apologies, things fly, to residency education are significant. Now, this is Teresa McLeod, my long distance mentor and role model. And when in 2000, she actually spoke at the Rankin Society when she was a president. She said that the future of a specialty is determined by the quality of education in our residency training programs. Okay. And perhaps the most compelling question for all of us to ask, are we really preparing today's residents for both today's and tomorrow's practice? And to some of these questions, the answer is no. This is my personal opinion. Good education for those of you who have children, okay, or were children, for those of us, right? They know that good education is expensive. The data show that high quality instruction lowers productivity by about 50% if you really are putting your heart into teaching. All right. The cost of training a radiology resident is estimated about a third greater than the direct salary and benefits. And the resident participation in imaging interpretation increases the average turnaround time by 45%. Just yesterday, I was reading chest x-rays, and one of my residents said, well, what do you do sort of without us? And I said, oh my God, I'll be about twice as fast. All right. And I'm not there to use them. I'm there to teach them, right? I could get into my, yoga outfit and sit at home and churn it out twice as fast, right? But that's not the point. The most important thing in a complex, disruptive environment, when we get stressed, we prioritize patient care in favor of less urgent. Let's insert education, research, consultation, and things like that. All right, remote teaching seriously strains apprenticeship. They're not right next to us, right? We can't motivate them quite as much. They cannot motivate us quite as much. All right. Most importantly, let's do data. Love data. Okay. With remote instruction, residents' productivity dropped by about a third. This is out of COVID, right? It dropped by about a third because all of a sudden we were remote. And you know what? It didn't come back after COVID was over. Okay, resident productivity did not come back. And because it is independently associated with knowledge and clinical performance, that's not a good thing. Okay. All right, technology to the rescue. We're much better off than we were even 10 years ago. We have a plethora of web-based lectures. We have the platforms for asynchronous learning like StratPrime and StatDX. right? We already putting in, many institutions, larger institutions are putting in AI case customization for an individual trainee. NYU is doing a beautiful job. It's just a gorgeous customized education system. UPenn is developing one, and they are on the horizon. A few more years, we will have bespoke education. But right this moment, the skill set and expectations of our residents do not match private practice. This is what the private practitioners have been telling the ACR now for many years, that community practices are finding it difficult to attract and acclimate new specialty trained hires. Do you remember 20 years ago the concerns that that we need more specialists, right, to protect out the turf? Let's call a spade, right? So as the result, the ABR examination turned more specialty driven. The certifying exam was basically a specialty test. And fortunately, the ABR is very attuned to the needs of radiology as a whole and is always looking to improve. And so the new test, the remote test, is going to be both oral and significantly more, general, so that the backwash effect of testing, i.e., all of us trained to the test, mean that we will be training our fourth years in general radiology, whereas previously majority of them were having, and to this day, they have many fellowships, and in the fourth year we begin, at least to some extent, specialty training. Also, the procedural skills are not adequate. Okay, and the new ABR exam is going to test to the best of the ability on oral examination, procedural skills as well. All right, very quickly, promise of technology. Who has seen the Netflix Better Than Us? Nobody? Strongly recommended. There are two versions of it. One original British, the other one is remake Russian. They're absolutely both are phenomenal. To date, and I looked it up last night actually, the FDR website shows 1,016 AI-enabled devices and algorithms cleared by the FDA, and 3/4 of them are in radiology. They're narrow in scope, primarily triage and detection. Those of us who use them, and I do, have opinions on them. Others are large language models. I personally don't use them, which apparently reduce, you know, shorten the work day significantly. Okay, and yesterday I found this paper in this is European Radiology, March 4, 2025. AI reduces lung cancer screening workload by 80%. Full disclosure, I find screeners repetitive and not terribly exciting, et cetera, et cetera. So I am loudly cheering for this one, right? Okay, but what is the state of adoption? Let's say it's modest. Only a third of us use it. 90% find it those use find it inconsistent. Yes, it is inconsistent, misses a lot of things. Okay, 80% see no benefit in it. Excuse me. Okay, 80% work in progress. Right, 33 cannot justify the investment. All right. Now we all understand that FDA clearance does not ensure safety and effectiveness. You have to check it all the time. I myself see a drift in performance, right? My AI all of a sudden stopped detecting malpositions in tracheal tubes. It stopped, okay? And I will be talking to them on Monday. We will have a meeting about it, right? So, Rabaya, remember? Yeah, yes. Okay, we know, right? And performance has to be validated in the specific environment. But AI is our future. We have a bill in Congress, right, to allow AI to prescribe drugs in a very limited manner. It's there. I didn't, I, yeah, I do data. It's there, right? Okay. Very, very limited manner, right? And AI really should complement, not supplant our logic and decision making, but only if we adopt it and don't fight it. Please remember, right? AI will not replace it, even if in some ways it is better than us. It will only replace us if AI and us, right, are worse than AI alone. Okay. So if the paired AI and radiologists are better than AI alone, okay, we will continue practicing happily ever after, but we need to adopt it. Okay. Conclusions, right? We have a crisis. We need a rescue. We are The radiology workforce is clearly insufficient for the today's needs and for the growing needs of aging population and further penetration of generalist healthcare practitioners, right? The demand is outstripping the increase in resident positions, even though this year already we're seeing a little spike. All right. We are experiencing understaffing, burnout, job turnover. Remote practice is impacting teaching, and the dynamic is unsustainable. If we cannot provide services in a radiology desert, right? If we are not available, then they will rely on AI. All right? Or they will rely on any low value commodity rendered without our input. We have to adapt. We have to increase residency positions and train faculty in remote instruction. And I have to persuade my institution to buy me more cameras for every workstation. Yeah, okay, those that go away if you leave them on top of the workstation. Yeah, okay. We need to create conditions to retain older radiologists like me, right? We need to recruit international radiologists throughout the ABR alternate pathway and not create conditions here in the United States where British Columbia yesterday announced that they're going to be competing for us. Right? British Columbia is now working on reciprocity, allowing us to get licensed in British Columbia. Yes, it's yesterday's news. I do data. Okay. We need to promote appropriate utilization to the best of our ability. Try talking to NPs and PAs. And we also need to investigate risks and benefits of AI and adopt it to improve care, education, and our productivity. Hey, thank you very much.